Hello, everyone, and welcome to our fifth session of CMEpalooza Spring 2023. Thank you all for joining us for our afternoon snack session, sponsored by Clinical Education Alliance. Think Again, Challenging the Path of Least Resistance. Our moderator today is Michael Platt from Clinical Care Options. I'm going to turn things over to Michael in just 1 minute. But first, of course, acknowledgement of all of our sponsors. A big thank you to our gold sponsors, Academy for Continued Healthcare Learning, Clinical Education Alliance, Med Learning Group. Our silver sponsors, Academic CME, DKB Med, Haymarket Medical Education, Helio CME, Integrity CE, Medscape, Platform Q Health Education, RedMed Ed, Talon Health. I read through all of those and forgot to read the slide. So here is Integrity, Medscape, Platform Q, RedMed Ed, Talon Health. Yeah, I get in a flow with these, and then when I make one mistake, it screws me up for the rest of them. Here we go. Bronze sponsors, Anderson CME, Antidote Education Company, Bonin Continuing Education, CME Institute, CMEology, Hippocrates, Excalibur Medical Education, Global Education Group, Infograph Ed, Integritas Communications, Iridium Continuing Education, MedIQ, and Partners for Advancing Clinical Education, PrimeMed, Peerview Institute for Medical Education, RMEI Medical Education, Vindico Medical Education, and Wright Edison. 2 ways to ask questions. You can use the CMEpalooza text line to send in a question, 267-666-0CME. You can also open up the viewing window in YouTube. Just click on the Watch on YouTube on the lower left corner, and you can use the YouTube chat function. Both of these work pretty well. I'll be monitoring these throughout, so feel free to use either one. We do have a few audience response questions. So that's poll everywhere. Big thank you to CME Outfitters for sponsoring our audience response system. If you haven't already, make sure you can either download the Poll Everywhere app and use CMEpalooza 005, or type in the URL that you see here in your web browser, also CMEpalooza 005. You can use either of these. Again, both of these work very well. Go ahead and get that open. We have a couple questions coming up throughout the session. Speaker disclosure. Opinions, discussions, and/or conclusions expressed are those of our panelists and do not represent an endorsement by or a position of their employer, its parent company, or affiliates. And so with that, I will turn things over to Michael.
Thank you so much, Derek, and congratulations to you and your entire team and organization. I think you mentioned to us this is your 20th anniversary.
20th CMEpalooza. We won't call it anniversary yet.
Okay, very good. Well, it's a privilege to be here. Welcome, everybody. And we have a provocative session, we think, today called Think Again, Challenging the Path of Least Resistance. And with that, I'd like to have our panelists introduce themselves. Derek, if you can move forward with the next slide. I'm going to go ahead and ask in the order of the topics, the truths that we're going to address. I'm going to ask Sarah, then Greg, and then Terry. Tell us a little bit about yourselves today.
Hi, everyone. Thank you so much for joining us today. I am Sarah Anderson. I am a scientific director with Clinical Care Options, part of Clinical Education Alliance. I'm also a pharmacist with 16 years of pharmacist experience. So I've served in a number of roles, both as the learner, the practitioner, and now officially in a CME role. So it's nice to be here and nice to have you all here.
Hi, everyone. I'm Greg Salinas. I'm president of CE Outcomes. I've been involved in outcomes assessments and other whatevers to do with CME for over 15 years and happy to be here.
Good afternoon, everyone. My name is Terry Bechet, and I work at Daiichi Sankyo. I manage the external education for the lung cancer tumor areas, as well as some emerging tumor areas. And I, too, am a pharmacist, so I'm really excited to be part of this panel to respond to some of the discussion as either a clinician learner or a supporter. So happy to be here.
Thank you, panelists. That's excellent. As a brief introduction to what we're going to focus on today, what do we mean by think again? Why are we challenging the path of least resistance, if you will? Well, I think many of us enjoy a good comedy and entertainment, And we're familiar with that traditional improv approach of yes and. And that's really what we want to focus on today, specifically as continuing education professionals. There are challenges with our time. We look to work smarter, not harder. So it's very easy to sometimes get in a groove and begin to expedite things. But the reality is, all of us are really focusing on how to address and close clinical practice gaps, improving outcomes for patients through quality education. But that's messy work. So let's consider maybe if we did a similar approach to what the entertainment industry does and others, and look at it a bit differently. Yes, and as we begin through our daily work of developing needs assessments, developing the instruments we're going to use in pre and post surveys, how we're going to look at outcomes and data, how are we going to look at knowledge-based activities and so forth. So let's consider battling in our minds this heuristic approach or these mental shortcuts that we take to really get the most robust and all-encompassing point of view to really drive some innovative education, if you will. So our experts here on the panel, subject matter experts, they're going to take apart and address one truth each. And Sarah's going to address the first truth, which is really focused on assessment question design. Then we're going to have Greg look at value of qualitative and quantitative data, really using open-ended outcomes data. And then Terry's going to look at knowledge improvement and actual change that can be accomplished maybe in one learning activity. So look forward to this robust discussion. And with that, Sarah, why don't you handle the first truth?
Great. Thank you so much, Michael, for that introduction. And so if we can go to the next slide, we'll pull up truth number 1. We thought this would be a great way to get the conversation started, both amongst our panelists and with the audience as well. So truth 1, what we're calling truth 1, is that in multiple choice question structure or creation, it is critical that we use 1 correct or best answer and 3 distractors to construct an effective question. And so like Michael mentioned, this isn't necessarily to dispel this truth or kind of bust this truth, but thinking about yes and. So this seems to be a commonly held practice in continuing medical education. It seems to be a common way to construct multiple choice questions. But how else could we do this? How could we do this better? And so our yes and here is yes, and oftentimes those 3 distractors are not all functioning distractors. And so there are, data in the literature, in the CME literature, as well as in health professions education, particularly in nursing education, that really challenges this truth and says we don't necessarily need that many pieces to a functioning multiple choice question. And so I think this leads us into our first polling question, if we could go to that next slide, because we would love to hear what you as audience members and learners here think about this. So how do you feel about this statement? Multiple choice questions containing fewer distractors, like 2 instead of 3, should be the norm in continuing education for healthcare professionals. Do you disagree and think that if all distractors are plausible, more should be included? Are you not sure? Maybe you don't know if this is an educationally sound practice. Choice 3 is that you agree there are data to support this practice. Or the last option, perhaps your feeling or opinion is not listed here. So if you'd like to go ahead and poll in now, and if you're leaning towards option D or the 4th option, that your feeling or opinion is not listed here, we would love to hear from you by texting in your thoughts on maybe why you feel that way or why you feel differently from the other choices. Great. So it's looking like about half of people who are polling in are not sure. So I'm so glad that we get to talk about this. So I think we can go ahead and close that poll. Thank you so much. And again, just bring up, this is the typical quote unquote recipe, if you will, for multiple choice question structure that we know in the basics of multiple choice question structure included question stem, 1 correct or best answer, and then several distractors. This is kind of an ad lib, if you will. And so we really want to talk amongst our panelists today about what we think about the more or less traditional multiple choice question structure, and whether we feel like it's necessary or a needed shift towards fewer distractors.
Excellent. So let's get a perspective from our panel. I know when we met in preparing, there was some robust discussion to this. Terry, would you like to provide that point of view that you had discussed both as a learner yourself and as a supporter?
Sure, yeah. So I think from a learner's perspective, I don't know if it's necessarily the number of multiple choice questions that really count, but I think it's the type of questions that are being asked that probably count even more so. Questions that really allow the learner to think through the responses being provided and see how they best can apply what they just learned to their practice and to their practice gaps that they've kind of set for themselves. So I don't know necessarily if it's the number of questions. I think one right answer should stand out amongst the rest. And I don't think the distractors should be anything that's really like off the wall, outlandish, where it kind of stands out as, hey, that can't be the right answer. But I definitely think the questions should really allow the learner to think more about the responses and how they could take the questions being asked and apply to the gaps they've kind of identified for their own practice.
Yeah, I think that's an interesting point, and I might want to push it just a little further and say that why do we have multiple choice questions to begin with? And because if you know anything, and I've talked about this a couple of times, is that I hate multiple choice questions. How often, if you're thinking you're a physician, a patient comes in your office like, hey patient, something, or hey doc, something. I either have diabetes, I have hypertension, I have this, or none of the above. Please choose one. That's not a real world. If we're really trying to measure how much someone knows and how much someone can apply something, is a multiple choice question the best way to go about it?
I think that's a great point. And I think to piggyback on what Greg just mentioned, I think one of the challenges that I experience in my role as a scientific director and being the person to put together the CME materials, work with the faculty on those outcomes questions, which oftentimes are multiple choice questions, is, gosh, how do we execute a level 4 outcome with a multiple choice question? In my previous life, I was in academia, and so very familiar with writing test questions for pharmacy students. And there was always a mix of kind of knowledge-based versus application-based questions. But we oftentimes used, short answer boxes or things like that for those more application type questions. And so even in my role as a scientific director, and again, working with practicing clinicians who are our faculty for the programs, it's oftentimes difficult to write a solid multiple choice question with one best answer, reasonable distractors that gets at a level 4 outcome.
Yeah, and I think too, Sarah, like as a supporter, so putting on a supporter hat, I think as a supporter, when we're reviewing the outcomes that providers share with us, and we're seeing the responses that learners are inputting from the questions being asked, sometimes it's really hard to extrapolate what to make out of it unless, the distractors are, meaningful distractors. So maybe it identifies a gap that still exists even after the education has taken place. Or it could be really telling to show that this education has really brought the learners to a different level point and maybe, has identified a real gain. So I really think it's really about the quality of the question being asked rather than the number of questions being asked. And so to Greg's point, it would be always great to, and I think, this kind of moves into your topic a little bit, Greg, but like to have the learner provide some qualitative aspects to it as well to add some robustness to the quantitative aspect.
I think it gets to the point of why a multiple choice question, and probably the reason it can all be pointed to is because it's easy to analyze. You can do a pretty easy, look at it, who said what percent said what percent said something, but is that the best way to do it? Why are we doing this? Is it for ease of analysis or to really see the effect of a program? And I think that's almost a cop-out a bit because there are other ways to do analysis. You can do short answer questions really easily. There was a session a couple hours ago about AI techniques. And now with AI technology, I think you can do some quick analysis of short answer questions pretty simply.
Mm-hmm. And then I guess the other question too is how much of it is guessing? I mean, you know, when we were kind of, you know, discussing these truths earlier, we had mentioned that, you know, sometimes the best test takers know exactly what answer to select. And, you know, sometimes they just guess through it to get, you know, that post learning survey out of the way. So I guess sometimes it's, you know, unless, you know, it's designed in a way to really make the learner think about how they can apply it and want to motivate the learner to take this post-survey question. A lot of times they're either guessing or they just know how to guess appropriately. So
exactly right. Yeah, medical professionals didn't get to where they are without being good test takers.
Yes,
exactly.
They're very good, and they'll see through a distractor pretty quickly.
Or process of elimination, like this definitely is not the right one.
Absolutely.
Right.
Well, and to that point, I think there's opportunities where you can offer, you know, another answer choice that's perhaps I don't know or I'm unsure, but then that muddies the waters of what are you really testing? Are you testing their knowledge or their application of the material or their confidence in that knowledge? And so not that we need to get into a whole discussion on that, but I feel like there's pros and cons to trying to manipulate the multiple choice system.
Absolutely. Great points. Sarah, I think you had mentioned that you and your colleagues, you meet regularly to help address some of this. Can you kind of just quickly maybe give that pearl to our colleagues in the profession?
Absolutely. Yes. So I am on the infectious disease team at Clinical Care Options, and our ID team meets once a week for an hour to have an outcomes workshop. And so all of the scientific directors, our supervisor, even members of our strategy team who are responsible for writing the proposals and grants, join us on that call. And we spend the hour workshopping these outcomes questions so that we make them, you know, as educationally and scientifically sound as we can. And it probably doesn't surprise you that we can oftentimes spend the whole hour working on one question. So we do try to uphold, you know, the best processes that we can to make our multiple choice questions robust. But I sense a shift in the future that multiple choice won't be the only way that we'll be assessing our learner base.
Right.
And I would almost say, if you don't have a team, you know, as well structured as yours, you could think about maybe piloting it. I think, you know, with knowing that sometimes with education and CME, you only have maybe 2 or 3 pre-post questions. So if they don't work, you're kind of stuck. So think about piloting it to a target audience. You know, maybe a couple people, a couple clinicians who are in your target audience. You know, how does this work? How does this question? How do you think about this question? And if everybody's getting it right, and it's like, oh, this is easy, and they haven't seen the education, so it's like, well, maybe we should rethink the way we're approaching this.
Right. Absolutely. Thank you for that great feedback panel. And with that, I think we want to transition to Truth 2. And Greg, let you run with that.
Sure. So Truth 2, go next slide. So right now, it seems, you know, we've talked about this, quantitative data is the primary means of assessing educational outcomes. Qualitative data is best used to affirm the findings of the quantitative data. So is that true? And is that the way we should go about doing things? Go to the next slide. I just kind of want to level set a little bit and what we really mean by quantitative versus qualitative data here. Quantitative is kind of what you think of the pre-post testing. It's the multiple choice questions. It's the, you know, maybe a follow-up survey. You can get really fancy with it and do a chart review and get some numbers, big data, but it's basically anything you can calculate, whether that claims data, prescribing data. Whereas qualitative, some say it's a little softer. Interviews, focus groups, nominal group technique, open-ended survey questions. It's a little more open for interpretation. So, you know, what is the best way to assess an educational intervention? Go to the next slide. I think we have our question here. So if you had to pick one, what type of data would you use to tell your outcome story? Would you prefer quantitative, qualitative? I'm not giving you a choice to choose both. We're getting some numbers trickling in here. Maybe 3 people have answered. Oh, here we go. 5 people. All right. About half and half. Okay. So I think, obviously you can use both. There seems to be a bit of a preference, slight bit of a preference to think about quantitative data. And that's fine too. I think the idea here is that it really depends on the type of education you're doing. And we can stop this, the numbers trickling in here, but if you have something that's a little more didactic, a bit more true, false, I'm here really to teach people about how to think about clinical trial data. Are they understanding what that data says and all that? Sure, quantifiable, quantitative data is the way to go. In the last session, they were talking a little bit more about some different types of learning and types of learning around shared decision making, perhaps types of learning around attitudes and how you're going to approach patient care. A quantitative true false multiple choice survey may not be the best way to assess that. And I guess my goal here is to open a little bit of eyes around the possibilities of an interview approach, an open-ended question approach, see how people would address a certain situation in an open way to really see what the learning is happening.
And I see a comment there, Greg, from the that popped up there about qualitative data. Do you want to respond to that? Align with it?
Yeah, I think you're right. Qualitative data has its value and is appropriate based on educational objectives. This is absolutely what I was talking about. If the idea here, and we see this oftentimes with the learning objective, is to discuss something, and then we have a multiple choice question to assess whether someone can discuss them. Well, if you really want someone to discuss something, you really need to have an open way of assessing that. So I think, having those conversations, what did you learn? What was new here? Can be just as insightful as I saw a 50% increase on option A in this pre-post survey.
Some good points there, Greg. Terry, would you want to provide your point of view, again, learner, supporter perspective, value of qualitative and quantitative?
Yeah, so as the supporter, so I'll provide this response as far as, my supporter side goes. I think, I like to see qualitative data. I think quantitative data is important, but I do also like to see qualitative data. And I guess it really depends on what therapeutic areas where they are in the evidence cycle. I think for emerging therapies, it's really great to see qualitative data because you may not have a field medical affairs that is actually out discussing with clinicians the data because it's still maybe not in the public domain or it's not FDA approved yet. So it's really great to see kind of what are their thoughts, where would they use this in therapy if it were approved, or what are some of the hesitations as to not, embracing that new therapy. I think once a product is in, it is approved. I think, maybe where quantitative and qualitative are both can be used, but I do feel that qualitative can add some additional value. And then as far as adding our value stories, when we, there was an earlier session that discussed, sharing outcomes with internal stakeholders. I think when we share our value stories with our medical stakeholders, our internal stakeholders, it's really nice to be able to provide that qualitative aspect in addition to quantitative, because there was a comment made earlier that our internal stakeholders, they don't talk CME. They don't really understand, what a 25% gain in knowledge or a 30% confidence increase really means, but they do understand quality and they understand the kind of comments that are being made by the learners. And I think it really can help, devise strategy moving forward as far as the type of education we can support to address gaps. And I think it also helps with their strategy, the internal colleague strategy, as well as whether or not this is a gap that needs to be addressed on a much broader level.
Sarah, did you have a point of view on the yes and perspective of qualitative and quantitative?
Yeah, absolutely. I think that we oftentimes get really mired in the quantitative piece and wanting to see those numbers. It's exciting when you see a pretest question perform, baseline, not great, but then after the teaching, when you ask that post-test question, all of a sudden, the correct answer jumps up. That's nice to see that. But again, is that a function of many of the issues that we discussed with the multiple choice question piece, including, do we have too many distractors? Does that mean that, someone's able to easily guess? Even to circle back to that topic, there are data to show that fewer distractors can be better because many times, that third distractor is not functional. And so again, some of that quantitative data, gosh, it's nice to see it when it's positive, but just, what does that really mean? And so I think from the science side of things, we like to see the qualitative piece added to that, in particular when it's a topic that may not be as black and white as, one correct answer with, 3 distractors that are incorrect answers. For instance, I had a program recently that focused on managing patients living with hepatitis B in certain patient populations. And the theme of the program was overcoming barriers to care, to access, to treatment, all of those things. And so it was tough to construct questions to ask the audience. And because what we really wanted was the qualitative piece, what can you or can you not implement in your practice, and what are the barriers that are prohibiting you from, implementing best practices. And so it's nice to see the quick quantitative data, but it's really the qualitative piece that helps us understand where our learners are at.
And there was a comment, I think, that just popped up from Brian about, if it's a challenge to tell the story around quantitative data, would it be that much harder to do qualitative? And I might push back a little bit on that, because I think the qualitative data can help tell the story of the quantitative. I think having both of those together might help bridge an idea where you might have just missed it to begin with, or like, I'm not really sure why people are wanting to go this way. And that's something we see often in a distractor, right? Like, why are people choosing this distractor? And they're like, oh yeah, we're getting it. Half the panel or half our learners don't have access to that medication, or they don't even, they would love to do this, but they can't for some reason. And we can maybe start telling that story that way. And it's not that they don't know this, it's that they can't do something for another barrier, perhaps. So I think it can maybe help bridge some of that and maybe link some things in your head. It's hard. It's all hard. But I think, having that extra piece and being able to think about something a little differently is helpful.
Yeah.
So that fills in the story there, right? That's what we're saying? Is that where you were going to go with that, Terry, about the completeness of it?
Yeah. So I see Brian's viewpoint about how it can be hard to tell the story, and it really, I guess, depends on, how much qualitative comments we're getting or how much qualitative data we're getting. If the N is really small, sometimes it could complicate things. But I also think that it's only one piece of the story that we tell. I think there's several different things that when we create our value stories or our narratives to share with our internal colleagues, I think it's one aspect. I think it adds nice flavor. But I definitely think there's several other things that we look at needs assessments. We look at the gaps that are in the, literature. We also look at the quantitative data, and we also look at, the insights that we hear from our field medical affairs colleagues, as well as, things that we're hearing, from advisory boards, if we're part of those. I think there's several different messages that we are hearing, and it's kind of one additional piece of the pie. And I think it does add additional, I guess, flavor to the story that's being told.
And it's not necessarily hard to gather. I think sometimes we're gathering qualitative data, whether or not we realize it. In a chat feature maybe of an online education, people ask questions, people put in things. Can we take that and use it in the outcomes? And like, here are things people are asking about. Can we aggregate that by theme? Did we address that? Is there a way? Saying like, yeah, people are asking about this, we addressed it, and maybe at the end, we can have some kind of question about, did you feel like your question was addressed? I don't know, but I think all of this data is coming in, and it's usable, even if you don't necessarily think this isn't necessarily outcomes data, but it can be used for outcomes.
Well, I was going to add to that depending on what data you collect or have on your learner base, depending on how your platform works and how your education, your different deliverables are delivered, you might be able to, analyze the quantitative data that you have by healthcare professional type. Perhaps there was a difference in how pharmacists responded to the question versus how physicians responded to the question. Getting back to some of those, challenges where someone might want to use the newest drug on the market but can't. Sometimes you'll see themes based on geographic regions, and so I think even if you have just the quantitative data, if you will, sometimes looking at it through those different lenses of the different learner types or perhaps where they're located in the country or in the world can also help with the story of how that education was delivered, how it performed, and maybe what the next steps are.
Sarah, I love that point. I think that's a really important point too, as we analyze the data and the outcomes that providers share with us. I think it's so important to see that demographic, like who is responding to those questions, because I think that can really clearly identify where we need to educate further. If we're seeing, I work in the field of oncology, and that's primarily the portfolio of what Daiichi Sankyo therapeutic area is in. And if we're seeing that, these are comments made by the oncologist, then something went wrong, but if this is, maybe questions that the care team are asking, then that maybe can identify like, hey, there's really a great need to start, educating the care team and beyond. But so I definitely think that that's important too.
Yeah, excellent point. And Emily just made a good comment, but there was a question that I'd like to pose to the panel. It talks about qualitative data provides an opportunity to explore causalities, but what should come first, kind of the chicken or the egg, qual or quant data?
That was exactly where I was going to go with that. It's a chicken or the egg question, because it depends, and it depends on your learning objectives. And I think sometimes you can use quantitative data to support your qualitative points as well, to show like, well, here's some attitudes that we think we're changing. Let's measure that, and we can measure that in a quantitative way of measuring attitudes, measuring barriers, measuring awareness. Likelihood to do something. You could pose certain patients and say, how likely are you to change their diabetes medication? And see, so you can do things in a quantitative way that may help answer your qualitative points.
Absolutely. And we've had some other comments where noting both should be used. There was comments of, I did a survey looking at perception of change with physicians compared to qualitative data, hospital performance, and patient outcome data, those different tools. Any perspectives on any of that? I mean, it sounds like a very valid approach, but any other points of view, Greg or panel?
No, I think that's all fine. I think that what I came to this talk and I just wanting to say is that qualitative data isn't just an afterthought. I think, you can even develop a whole outcome strategy around it as the principal means of data collection. And I think that sometimes it's used like, well, we have a comment box at the end of our pre-post, and we'll gather some comments and put them in. But I think if you have a strategy and have a way to say that this is important, we want to know the answers to these questions. We want to know how it's impacting your practice specifically in some of these ways, and we want you to tell us. Having that as a principal means of data collection is important.
Right. Panel, really thank you for addressing that second truth. And with that, we're going to move on to truth number 3. And Terry, I know that's something that you have a very strong perspective on.
Yeah, so it is possible for practice change after a knowledge-based activity. So this is a yes, and provided that decision science was actually built into the intervention. And I think, one important thing so this is based on research that we conducted. Our office in Grandson Education Department conducted this research. And we're not suggesting that practice change can occur after one activity, or that learning is not an evolution. It is a practice. It takes several times for a learner to hear the information before they can change practice. But what we are suggesting is that even the smallest changes made by, a knowledge-based activity built with decision science can be clinically meaningful. And what I mean by, decision science being built in, it's really having the learner kind of think through the information and how it best can apply to their ecosystem immediately. So I had, I had mentioned earlier about, having the learner kind of identify their own practice gaps and really having them kind of create a decision analysis about, what are some steps moving forward based on what I heard? What are some of the outcomes if I implement these steps? And what's like a path moving forward? And I think that decision science built into a knowledge-based CME can look, and feel in a variety, it could look different and feel different in a variety of ways. One could be through nudge science, really making sure that the learner continuously sees and hears this information after the activity takes place. Another could be through the types of questions that are being asked. So very, appropriate to what we were discussing earlier, the types of questions that the pre-post questions that, are being asked of the learner. So to Sarah's earlier point about multiple choice questions, if we could say, based on what you've learned, select the words that best describe what you would have done differently before hearing this education, or select the best words or phrases that best describe the goals that you have after this education. Or if you add a qualitative aspect to it, to Greg's point, what are some actions you plan on taking when you see patient X or patient presenting with, this diagnosis, or what are some goals that you have after hearing this education? I think all of this can really, move the needle and be clinically meaningful. The reason, just to give a little quick background, the reason that we conducted this research is for a number of reasons. I think we had all mentioned, and, like I said, there was an earlier session about outcomes and telling our narratives. We all strive to create our value stories and share this with our internal colleagues. And, we do this either through the outcomes that are shared, needs assessments, literature searches, learner feedback. And at the time that we created this research, a lot of our therapeutic areas were considered positive emerging evidence. And, when we looked at the research to see what impact does knowledge-based CME have on clinical decisions, there was over 3,000 references that came back, and none of the references really showed a direct correlation. And if it did show a direct correlation, it was by self-reported responses that weren't statistically validated. So we didn't really find anything that was very referenceable. Also, a lot of the references were over 10 years old. So we actually conducted a 20-question qualitative and quantitative survey. We asked our partners in Med Learning Group if they wouldn't mind disseminating it to their willing database of learners and who have participated in knowledge-based CE activity with decision science built in, irregardless of whether Daiichi Sankyo supported that activity or not. And the results that came back were really meaningful. And just kind of putting in a shameless plug here, we are going to be presenting the results of this at the Alliance. It's called Revisiting the Basics. Declarative and procedural knowledge-based and decision science can lead to clinically significant outcomes. But just as a preview of that, we got about 499 HCP responses back. And what we found was really valuable, and that was statistically analyzed. So if we go to the next slide, I'll have a polling question about one of the questions. So according to this research, what is the average percentage of practice change that can occur from a knowledge-based activity that incorporates decision science? A, about 33%, B, about 75%, or C, about 82%.
Here we can test our multiple choice guessing here.
Oh, wow. Okay. Every single person got it correct. So
it's still coming. It's still coming.
Too soon. All right. Well, okay. So the correct answer is B, 75%. And I think I guess the takeaway is that as a community, we're always looking for innovative approaches to bring education to learners. And we're always looking to, do complex designs either through quality improvement, performance improvement initiatives, or PDSA. And I think we definitely value those, and so we support those activities. But I think depending on the evidence cycle, I think we shouldn't undervalue knowledge-based CME built with decision science, because it can definitely lead to clinically meaningful impact for learners and patients.
Thank you, Terry. That's great.
So,
It's interesting to see the survey there. I know when you asked us on the panel, I was wrong. I thought it was 33% myself. So, it's really good and interesting research and a refresh. Panelists, no particular order. Sarah, Greg, you want to provide your point of view?
I mean, I don't think we can expect any practice change without knowledge change. I mean, it's part of the continuum. So that just makes sense to me. I think that oftentimes we don't assess practice change with every CME activity, and we may not need to, but I think that it makes sense to me.
I was going to say, if I put on my pharmacist hat, or being on the learner side of things, in the 16 years since I've been a licensed pharmacist, there have been a lot of therapeutic changes to many areas of practice. And as a practicing healthcare provider, I don't know, you need the knowledge piece first before you can jump through those hoops of the application piece. And so you need to know about the new drug. You need to know about the efficacy, the safety data. You need to know where it fits in with the current, armamentarium of other drugs for that particular disease state before you can then, work through the next steps of, what is this role in my patient? What is this drug's role in my patient population, and those sorts of things. So I personally, from the healthcare professional side of things, I do see knowledge as the first step, almost like, you have to learn to walk before you can run, type of scenario. And I think that can be very beneficial to the clinician.
I think the challenge with it is to understand, again, if you're looking for practice change and you're providing knowledge, you just might need to think about, how do you help that learner make that leap? Do you provide anything? Like, sometimes there's nothing they can do, right? It's clinical trial data. Here's some things coming. There's nothing you can do right now, but here's something you can do soon. And so I know there's that challenge. But is there a pearl? Is there something that you can do right now? Can you talk to your patients that there's something coming? Can you be looking for a patient who might be better suited for this treatment algorithm versus another one? So there's something that as educators, we can at least prime it a bit to have that practice change when they can.
Yeah, and I think also in the field of oncology too, I think, the data is changing so rapidly that a lot of times clinicians, especially in the community, they don't have time to participate in really complex activities, that sometimes all they want to do is participate in, quick procedural and knowledge type of CE to get the latest information about what are the guideline updates, or what are the newest emerging therapies, or what is the latest genomic testing that I need to be conducting on my patient. And I think that this can really have an impact on patients. Just even knowing, the most up-to-date and emerging therapy, because it changes so rapidly. It really does.
That's a great point. And I think that when you think of the cognitive load it requires to just kind of, take in versus to really, if we have a very performance-based, I've got to work these simulations, I'm going to have to talk and discuss with my peers. It's a little bit more than some people may be ready for, say, at like an 8 o'clock symposia at their conference. So, and we see that too at our conferences. Like, how often do we have like, oh no, I've got to do something at this session. I got somewhere to be. So I think just to think about how we can maybe use some of that and make it work, even if it's just a didactic lecture or just getting data.
Mm-hmm.
That's a good point, Greg. And since this is all, we can all see how this all intertwines, everything that everybody's covered today, these three truths, quite honestly, it all fits together in some way or another. How about looking at, your symposia is on the third day, okay? And it's a topic that's kind of a hot topic these days. And at the professional society meeting, tons of posters, plenaries, program focus is really on that area. And first of all, the MEC and the faculty come up with the instruments for the survey, Sarah, like everybody had done. But all of a sudden, they get there to that last day of that symposium. You flash it up there, and you do your pre-activity. and it looks like everybody's already mastered the content because they're already predisposed. There was actually significant learnings on that almost 3 days. How do we handle that? And it's specifically if in the grant itself, we were talking about knowledge based and so forth, learnings, etc. And I just kind of like hear the panel. What do you think the educators there, the MEC company, the faculty, anything be done in real time with that? And I'm just asking a provocative question there. What do you think?
I will say, as the scientific director who's often in charge of executing those programs, that's something I lose sleep over sometimes. We just came back from running 5 satellite symposia at ID Week, and so that's absolutely something that can happen. 2 of our 5 symposia were the 3rd night, and so your question is very timely. And I think where my mind immediately jumps is that I feel like in the continuing medical education space, we do a really nice job of recruiting the best of the best faculty. And I think that while they're, not only well-versed in guideline-based therapy and, the package label information related to the medication, they also are practicing clinicians themselves. And so I think that in the scenario that you mentioned, I would probably powwow with my faculty, ahead of time, maybe to plan for that would be the best scenario. But perhaps, we can often communicate with our faculty while they're on stage through an iPad, and it might be worth posing some questions and maybe, pushing some of those more provocative questions out there to the audience, even if it's more or less unscripted, to say, gosh, it looks like everyone really has a great baseline understanding of X. Why don't we just delve into why? Why don't we, take this a step further? Why don't I give you a scenario that I saw in clinic last week, and really leaning on those, those experts that we've, recruited to conduct the education to really share, those gray areas or those, what if scenarios, I think is a way that you could perhaps pivot in that scenario.
Absolutely. We got a couple questions that came in, and Terry, they're really directed toward you. How was the impact of knowledge measured?
So I had one comment that popped up and I did get distracted by it. Is there any way to pull it back up about
Derek, can you pull that back up for us? I don't know if we can see that.
Yeah, give me a minute.
It was about something about practice gaps identified by the learner. And I really agree with that. I think the learner, yes, practice change is dependent on self-identified and acknowledged gaps in practice by clinicians, as well as support needed to make changes. I completely agree with that. And I think, every learner is going to have their own practice gaps. And there is this decision analysis that they kind of have to create for themselves, setting their own objectives, determining potential actions, predict the outcomes of those actions, and determine a path forward. And I think, it really is about a lot of different analyses that they kind of have to conduct on their own to decide whether or not, the knowledge they heard will impact, their day-to-day. How likely are supporters, it says, to support a knowledge-only program? And, that's a really interesting question. So for me, I have a lot of I have some therapeutic areas that are, considered out on the market. So it's like established evidence, and then other that's more emerging. And I actually find it sometimes confusing when I get a proposal that has practice change built into it, or like a level 5. And I think, how is that possible if the product's not even out on the market yet? So I think that I would, for my emerging areas, we all discussed, I think knowledge is a first step. I would like to see knowledge and confidence, especially if the area that in which they're educating, obviously there's always more than one educational objective. So if one of the additional educational objectives is around an area that maybe is already has been discussed previously, I think having a mixed methods, having knowledge and confidence, or knowledge and competence, I mean, they're really critical first steps before we can move to, a practice change type of activity.
Excellent.
So I would support it. So.
Absolutely. And you may have answered this, Terry, and I apologize if you did and I missed it. There was a question earlier about how you I believe in your studies and research, how was impact of knowledge measured? Did you cover that already, or maybe you could?
So they everything was statistically analyzed. There was a 20-question quantitative and qualitative survey with Likert scales and open-ended questions. And what they saw was that there was a change in personalized diagnosis made, ordering of diagnostic tests, and actual alteration of care plan implementation skills. So, and more of this will be discussed definitely at our session at the Alliance meeting. So we'll go into greater detail on all of this at that session.
Excellent. Well, at this time, I don't see, if we have more questions pop up, that'd be great, but do have Derek.
I do have one. Yeah, I do have one question just came in. I can't type fast enough, so I'm just going to start reading them. How successful are you in having faculty pivot in real time to move past content that shows high baseline?
That's a great question. I can at least start the conversation on that one. I think it takes some pre-planning. I know that in some of my programs we've discussed and created almost an overage of content so that we have some wiggle room, and we may have extra slides that we'll hide, and we'll say, you know what, if it's feeling like we need to really focus on more of the knowledge side of things, we'll do that. But if that goes fairly quickly, if there's some slides we can skip because the baseline knowledge based on the pre-survey question tells us that the audience really knows this already, then we'll have some hidden slides that we can pull up, or you can hide them, you can put them at the end of the presentation. But sometimes we create a little bit of extra content so that we can pivot to that. I would say another successful way that we've done this is through the use of cases, and allowing faculty the creativity and the room to really dive into a certain point on a case where, maybe it's not structured in the slides so much, but the faculty has the case, and we can, discuss ahead of time kind of ways to emphasize certain things depending on how the flow is going and depending on what the audience kind of wants and needs. But it doesn't mean any of it's easy. I mean, I rattle this off like, oh yeah, we do this all the time. Our hope is that we don't have to do that, but it's always, the best defense is a good offense. And so planning for that ahead of time, and having some of those things built in for some flexibility, I think can be helpful.
I think it's also acknowledging the environment you're in. If you're at a major medical conference society meeting, you're in an environment of learning. And if you're later in the agenda, it's smart to do that. So that's great insight, Sarah. It's good pearls. Speaking of pearls, before we wrap it up, do our panelists, any of you have any challenges for our colleagues that are out there, or pearls, anything you want to finish with? Any last comments? No? Okay. I didn't think so, but wanted to give you the opportunity. Just as a reminder to all of you, one, we really appreciate your engagement today and the feedback and allowing us to share this time with you and our points of view of saying yes and as it relates to really closing these clinical gaps and as we develop these educational programs for HCPs. So the next time when you're looking at your assessment question design, looking at quantitative data or qualitative data or both, or knowledge improvement, the value of it, make sure you take time to say yes and consider everything that you can. I know it's really easy to check a box. It's really easy to want to expedite things, but consider the value and the meaning to the learner and to the supporters, to all of your stakeholders. If you add that little bit of extra yes and, how much further you and all of us can go. So with that, I wanted to thank our panelists. Thank you, Sarah, and thank you, Greg, and thank you, Terry. And Derek, thank you and all of your group. So with that, I'll turn it back over to Derek.
Thank you, Michael. And yes, just to reiterate, thanks all of you for participating. Really great discussion, great interaction from the audience as well. More questions even coming in. So appreciate everyone tuning in and for all of your content today. Let me go through. Oh, there's a thank you slide. All right. So the CMEpalooza scavenger hunt is still going on. A good number of people have already participated. Thank you to all those. Or you can go to our sponsor's website, Skin, Bones, Hearts, and Private Parts, and look for the CMEpalooza logo and click on that. We have our survey, of course, just on the live page where all of the links are for all the sessions. At the bottom, there's a link to the survey. Please take a moment to fill that out when you have a chance. We do appreciate all of your feedback. And then lastly, the next session, which is coming up at 2 p.m., is Case Conundrums in CME. I think this is our 5th or 6th Case Conundrums session. I still can't figure out how to spell conundrums, but it is sponsored by Helios CME and Academic CME. That gets started right at the top of the hour at 2 o'clock. So you have 5 minutes if you need to get any refreshments and get ready for the next 3 sessions of the afternoon. And I will be back at 3 o'clock. So thanks again to all of our panel. Thanks again to Michael for moderating. And everyone enjoy, and we'll see you back here in a couple minutes.
Thank you.
Thanks.